Transposition of the great arteries. You've heard that term a couple of times in the last 2 days. I would venture to say that I don't think there's any other lesion that we see, any other anomaly in congenital heart disease that has had such an impact on its outcome from prenatal diagnosis as transposition of the great arteries. It is critically important that this be detected before birth because, and as I'll show you, the physiology of this particular condition is such that any newborn with transposition has incredible vulnerability. At the moment, the statistics are still in flux, but generally, probably only about half of fetuses with TGA are detected in the USA today, maybe even a little bit less than that. And there are major regional differences around the country. Babies that are born with TGA that are not detected prenatally can linger for hours before a diagnosis is made, and those hours are a ticking time bomb that critically lead to either the death of that newborn or to ultimately IQ points later on if the child does survive, if the newborn does survive. So why am I giving you this sort of introduction? Because this is the front line right here. You are the folks who need to be able to recognize this condition, and very practically speaking, if you can pick this up, you will be saving lives. There's no question. So with that dramatic introduction, what is TGA? Very simply, it is defined as a condition in which the aorta arises from the right ventricle. And as you see here, the aorta is coming off the right ventricle. Normally, the aorta comes off the left ventricle. What's wrong with the aorta coming off the right ventricle? Well, the blue blood that returns from the body, instead of going to the lung, is going to go back to the body. Whatever pink blood comes back from the lung is going to go back to the lung. So we have a situation of blood flow that's not oxygenated, making its way back to the body. And so babies with this condition are extremely blue. How do they not all die immediately as soon as separated from placental circulation? It's because there are still some natural pathways for communication between this very blue side and pink side, either at the top chamber, at the atrial septum, the foramen ovale, or at the level of the ductus arteriosus. So some of the pink and blue blood mix, and it allows for some degree of oxygenation to take place. But these babies are extremely fragile, and again, if not detected prenatally, will linger somewhere for a few hours with constriction of the ductus arteriosus, or just the simple changes in the transition to newborn physiology can become quite troubled and very, very blue. So notice the simple definition here of transposition is the aorta arises from the right ventricle. And this is a diagram of where the right ventricle is sitting on the right and the left ventricle is sitting on the left. The same nomenclature, the same title of transposition holds true as well in the condition in which the ventricles are switched. So what if this right ventricle were sitting on the left side and the left ventricle sitting on the right? By definition, we still have transposition because the aorta is arising from the right ventricle on the left side of the heart. But now this is referred to as, quote, corrected transposition. So important to appreciate when we refer to a, quote, corrected transposition, we're not necessarily talking about the arterial switch operation, which I'm going to go through with you and explain, that you're fixed, that you're repaired, but, quote, anatomically corrected, naturally corrected transposition is where transposition holds true, the aorta arises from the right ventricle, but the right ventricle is in the wrong position. It's sitting on the left. And so therefore, blue blood still makes its way to the lung, pink blood makes its way to the body. So these babies with corrected transposition are not blue at birth, but they have other complications. They can have problems with their right ventricle long term because the right ventricle is functioning as that workhorse, that heavy loaded ventricle that's doing all the job of delivering blood to the body because it's connected to the aorta. And it can fail over time. The tricuspid valve that leads into the right ventricle sitting on the left side can be malformed and can leak as well. And this can be problematic. And because the ventricles are on the wrong side, there's a twisting of the heart, is the way I think of this. And that abnormality of the twist of the two pumping chambers also twists the conduction system, the wiring that provides for electrical signals to make its way down to the ventricles. And when that happens, that electrical system is at risk for heart block. Okay, so we see heart block in corrected or L transposition. We don't see it in the D transposition, which we're going to spend the rest of the lecture talking about. But I thought it would be an important point to distinguish these two here at this point in time. We saw some beautiful examples yesterday of LTGA, or corrected transposition. So getting back to D transposition, which is more common, another terminology would be to describe there as being discordant ventricular arterial relationships. So the atrioventricular relationship is normal, but the ventricle to artery relationship is now abnormal, with the aorta arising from the right ventricle and pulmonary artery from the left ventricle. In this configuration, the aorta typically sits anterior and rightward as it originates from the right ventricle. It occurs about 20 to 30 per 100,000 live births. So it's not one of the most common forms. It's, I think, either number 3 or number 4 in the various listings of commonality of different forms of congenital heart disease. It appears to have a very strong male predominance. About 2/3 will be male. And interestingly as well, in comparison to some other forms of structural heart disease, it has a relatively low association with extracardiac or genetic malformations. Less than 10%, I'm going to say probably even less than 1 or 2%. And most fetuses with transposition, in my experience, with an intact ventricular septum, do not have associated genetic or chromosomal anomalies. Say, unlike ventricular septal defect or tetralogy of Fallot, which could be as high as 30 or 40%. In association, one can see some additional cardiovascular abnormalities. Atrial septal defect, ventricular septal defect is seen in about 40%. Left ventricular outflow tract obstruction, which is now going to be pulmonary outflow obstruction because the PA is coming off the left ventricle, seen at about 10 to 15%. Right ventricular outflow tract obstruction, a little bit less, and about 10% have aortic stenosis or coarctation of the aorta. And this abnormal configuration of transposition can also be seen within a context of other more complex conditions, such as single ventricle tricuspid atresia, and we talked about the congenitally corrected TGA. Again, to hammer away at this point and to continue to emphasize it, there is no greater condition that is deserving of prenatal detection than this particular malformation. Dramatic changes take place as soon as the baby is separated from birth. There is the potential for great hemodynamic compromise and an inability for adequate oxygenation, and there's an effective treatment, which is if you know you have a fetus with transposition, one needs to be ready to keep those natural communications between the right and left side open early after birth until we can stabilize the baby, confirm the diagnosis, and get to a more definitive treatment, which is the surgical arterial switch operation. And those temporizing measures include things like starting prostaglandin infusion to keep the ductus arteriosus open to allow for exchange, or quite commonly, to open the top chambers, the intraatrial communication, through a procedure known as a balloon atrial septostomy that allows for mixing and an improvement in oxygenation. Again, neither of these are treatments that cure the problem, but they temporize that intermediate period between the safety of the womb, maternal oxygenation, and ultimately the operation, which will take place typically at a few days of life. We need to bridge that physiology by creating adequate mixing between the right and left sides. And you can only prepare to do that if you know about this prenatally. So let's look at a couple of simple box diagrams that sort of follows the direction of blood flow. So here are the flow patterns in the fetus with transposition. Here's the right side, aorta coming off the right side, left side, and pulmonary artery coming off the left side. The foramen ovale, atrial septum, is bowing right to left, as you would normally expect to see, and there's a wide open ductus arteriosus joining the aorta and supplying blood flow to the body. Systemic venous return makes its way to the right side, the blue blood. Oxygenated blood from the umbilical vein returning from the placenta and streamed and targeted by the trumpet shape of the ductus venosus, angles that more highly oxygenated blood across the foramen ovale to the left side. So again, this is what's happening in utero. So the right side sees bluish blood. The left side sees pink blood. From the ventricular perspective, not terribly different than normal, but the two great vessels are switched. The aorta is coming off the right side. So in comparison to normal, what's happening here is the aorta is seeing, in utero, a greater degree of deoxygenated blood than it normally does. And so the coronary circulation and the cerebral circulation is seeing a little bit of a lower saturation than it normally would if that aorta was sitting on the left side. What is sitting on the left side is the pulmonary artery and the ductus arteriosus. Those two circuits, the pulmonary circulation and the ductus arteriosus itself, as they mature, increase their sensitivity to oxygenated blood and can respond to the streaming and change their particular contour and their particular resistances. So what are the consequences of in utero of these vessels being switched? There's a lower O2 content, relatively speaking, of blood flow delivery to the brain, a higher oxygen content to the ductus arteriosus, which is again now coming off the left side. A relatively decreased blood flow across the ductus arteriosus because now the ductus arteriosus is arising from the left side of the heart as opposed to the right side of the heart. If you recall your general fetal physiology, right versus left ventricles, the right ventricle delivers about 60% of the cardiac output, the left ventricle about 40%. So there's less blood being pumped by the left ventricle. The ductus arteriosus is now coming off the left ventricle. And it's being exposed to a more highly oxygenated blood content. What does that lead to? The ductus arteriosus can slightly constrict, or it can be somewhat smaller than normal. And that's typically the case. I'm going to show you some images of that. The smaller ductus arteriosus may reduce blood volume through the LV and decrease atrial level shunting, and then leading potentially to atrial level restriction as well. So the foramen ovale in TGA can be somewhat smaller than normal. And that puts those newborns at risk for not having adequate mixing once they're born. So what happens at birth? Let's go back to our box diagrams here. Transposition, the aorta is coming off the right ventricle, pulmonary artery off the left. The blue blood is returning to the right side of the heart. Pink blood now, lungs are open, was separated from the placenta, so pink blood's coming back to the left side of the heart. So long as you have an open interatrial communication, you'll have exchange of blood at the top chambers, and that increases the oxygenation that's ultimately getting to the baby's body. Wish we would be this pink, but typically it's pink enough to get adequate oxygenation. And if the ductus arteriosus is open, the general net direction of flow is from aorta to PA, more blood going into the PA, more blood returning to the left atrial pressure goes up, and this is the perfect situation we'd like to see in a newborn with transposition. We have an open interatrial communication and an open ductus arteriosus, and we are encouraging that pink blood from the left side of the heart to make its way to the right side and adequately oxygenate the aorta and adequately provide for systemic oxygenation. Wish that we were always this way in TGA. It's not the case. And so here's what happens when we have a newborn where the atrial septum is either restrictive or intact. Naturally, the atrial septum will close when left atrial pressure goes up. It's a trap door, physics, and if the pressure goes up, that door closes, and you can restrict shunting at the atrial level. That's great. It's what you expect to see in a normal newborn, but that's not what you want to have happen when you have transposition. So look what happens if you don't have that opening at the top chamber. Your ductus arteriosus is still going to be somewhat open. You fill the left atrium, but now you've shut that trap door. You don't get mixing from the left oxygenated side to the right side, and the right side can become profoundly blue. And these are the babies that have extremely poor blood gases, are acidotic, and again, the clock is ticking in terms of recognition of this phenomenon if you don't know about it beforehand, and then trying to implement a strategy of treatment. Behind the eight ball, being reactive to a catastrophic situation as opposed to being proactive and preventing this circumstance from occurring. So let's look at some images. And again, I'm biased because I'm giving the talk on transposition, but I'm going to say this is probably the most important thing I think that anybody in this room can learn, which is to become comfortable with recognizing the normal crossing vessel relationship of the aorta and the pulmonary artery. It's something I would encourage you to do with every one of your studies where you look at the fetal heart and get a feel for this. We can describe it. Michelle can show you beautiful images and arrows that are pointing to where things are, but nothing is better than getting your hands on a transducer and getting this image regardless of where the fetus is lying and getting a feel for that normal crossing relationship. It should be like driving a car for you, automatic, that you feel it, you can tell it's right, and you can tell when it's not right, when something doesn't look right. PA should always be bigger than the aorta, and they should cross each other when you look at the outflow tracts. Now, here's the setup. Of course, I'm going to show you an example of where if you're in a busy clinic and you've got a lot of patients waiting, and your administrators are telling you can only have 30 minutes for an echo, and you can't, spend any more time than that, and families are waiting. You get this beautiful 4-chamber view, and okay, looks great, move on. Well, sad to say, but this is the situation still for many ultrasound centers in the United States today, where we don't take enough time to look at the outflow tracts. So this very same patient who has a completely normal 4-chamber view, let us look at the outflow tracts. Those two vessels are not crossing. And it is a matter of anterior angulation and seeking the origins and the positions of the two vessels as they come off each of the respective ventricles. They're not crossing each other. And as we angle just a little bit more superiorly, you can see that those vessels are truly running in parallel. And the color Doppler here helps a little bit. What can we say here about which is which vessel? I think it's important to do that, but at the very least, the first step in this sort of mental process is to recognize that these vessels are not crossing each other and something is wrong about the great arterial relationship. Let me go back and point out each of these. So this vessel here, let me get my arrow, there we go. This vessel here is coming off the left ventricle, and you see that it bifurcates into two branches that are entering into the left lung. So another sort of mental trick that I'll often use, sometimes it can be difficult to distinguish which is pulmonary artery, which is aorta, because naturally they both branch at some point. We always say, well, that one's branching, that one's not branching. Well, both vessels branch. The pulmonary artery just branches much earlier. And it branches into two vessels that go into each respective lung. The aorta branches as well and gives off a branch that is the innominate artery and the head vessels and such. It can be a little bit confusing if you don't have sort of the right distance in mind here. Another way to think of this is go out into the periphery, find the vessel, and trace it back. So when you do that here, if you drop your scale properly and you can identify an arterial vessel in the lung, usually the left lung, and track it back, if it turns into a vessel that then connects to the left ventricle, that's your pulmonary artery. That's coming off the left ventricle, and you've confirmed that you have transposition of the great arteries. Another case, lung axis view, looks like a pretty reasonable 4-chamber view here, but then again with anterior angulation and positioning of your ultrasound beam a bit more cephalad, you can see that we have these two vessels arising that are in parallel and do not cross each other. Aorta anterior and rightward coming off the right ventricle, pulmonary artery off the left ventricle. An example of where we see TGA in something that's a bit more complex. So here's a 4-chamber view. As we angle towards the outflow, you can begin to see there's a particular septal defect. And with a little bit more greater clarity and an arrow to help us along there, you see that, in fact, that's a pulmonary artery coming off the left ventricle, and there is some subpulmonic narrowing. The arrow is pointing to something known as the conal septum, which is the part of the ventricular septum that sits beneath the two great vessels, and it is positioned posteriorly, deviated posteriorly, another term we use is malaligned posteriorly, into the LV outflow tract, causing some moderate degree of subpulmonic stenosis, and this is one of the more common forms of TGA VSD pulmonary stenosis. So, so here's where the arrow now is pointing once again to the posterior malalignment of the conal septum, the ventricular septal defect here in a case of TGA VSD PS. Once you've made the diagnosis of TGA, taking it down to the next level, okay, what else, what other piece of information do we want to have? And it is concerning those two structures that are going to be critically important to recruit immediately after birth to allow for exchange of blood between the two sides of the heart. And they are the ductus arteriosus and foramen ovale. Now, there's more to say about the ductus arteriosus. I think it's quite interesting. I'm not going to dive too much detail into it because there are circumstances, interestingly, where you can see reversal of flow in the ductus arteriosus in TGA. And I think that may be a clue that may explain why we see a smaller foramen ovale and a higher degree of restriction at the atrial level. But when you're looking for the two arches, as we've seen all along here, the aortic and ductal arches don't typically sit in the same plane, except when you have transposition of the great arteries. And here you can see we can identify the entire aortic arch superiorly and the ductal arch just beneath it. Aortic arch and ductal arch with the ductus arteriosus joining the descending aorta here. And in this particular case, blood flow is all anterior. This is late in gestation at 36 weeks. And this is what we're all trying to look for and predict as best as we can. It's one of these things, you know, you've heard people say it that, you know, I can't explain it, but I know it when I see it, sort of thing. This is one of those phenomenon where multiple investigators have tried to explain what it is that may predict the development of a small foramen ovale, but sometimes prenatally you can actually see a small foramen ovale. And this is in a case of transposition. And we looked at this and we said, well, that's probably not going to be terribly open after birth, and this is therefore a fetus that is at risk for not having adequate mixing. And therefore, we might want to prepare at delivery for an urgent balloon atrial septostomy, which is that procedure to open the atrial septum. No worries. No matter how big you make this, the surgeon will pay attention to it and close it at the time of the arterial switch. So making a nice big tear in that is not going to be harmful. It can only be helpful. This is Bill Rashkind, who was at CHOP in the 1960s and 70s and developed this technique. He is referred to as one of the fathers of pediatric and congenital cardiac intervention. And in a garage in a house not too far from where I live, he put a balloon on the tip of a catheter and developed the technique for passing this into the heart of newborns with transposition. And by blowing the balloon up and pulling it across the atrial septum, one can open that region and allow for adequate mixing and oxygenation. And in a modified way, this is still what we do to this day. So if you know that you have a fetus with transposition, how best to plan for delivery. The statement from American Heart Association, you've seen this cited a number of times, actually quite a good document to keep and to read when you get a chance and to refer to it. It harks very true for many of the basic principles that we're talking about as it relates to fetal heart care overall. One of the clear statements they made without any hesitation was to say that fetuses with DTGA should be delivered in a hospital that can manage the hypoxia and hemodynamic compromise that can occur. So if you know about this ahead of time, this is not the sort of baby that can deliver in a local community hospital where you anticipate that it might take hours to transport such a newborn. Again, the clock is ticking when these babies are born. We have a situation in my institution where we actually have a delivery unit in our children's hospital, and so we've created our own classification system for how we position the resources that are necessary to manage newborns with transposition. So babies with transposition are referred to as class 3 in our system, which means there's a possibility or likelihood of hemodynamic instability, and therefore neonatologists, cardiologists, everybody is sort of aware to the fact that such a baby is being born. we may need urgent care. We may need to call in a team to perhaps reserve a cardiac catheterization laboratory to perform a septostomy or to do it at a bedside under echo guidance in the ICU. It's just a way to notify folks and to create this alert within the system itself to optimize resources. And once we've created that stability for these newborns through administration of prostaglandin by opening the atrial septum, in some circumstances we can actually even stop the prostaglandin if you've got a good intra-atrial communication and good mixing there. But all of this is a bridge to get us to the more definitive operation, and that is something known as an arterial switch operation. So here's a diagram of transposition with the aorta arising from the right ventricle. And what we've added here, importantly, in this figure, are the coronary arteries. These are critically important because when one is going to transect these vessels and place the aorta back to where it should be on the left ventricle, you need to bring along the coronary arteries. Those are the structures that need the high pressure to be perfused by the aorta. You cannot leave them in situ connected to the pulmonary artery because the pressure on the right side will be too low after the arterial switch. So this is where the skill set comes into play in cutting out these tiny little buttons that you see here around the native aorta. And then by switching the vessels, bring the aorta back onto the left ventricle, one reattaches or reconnects these coronary buttons. These structures are 1 to 2 millimeters in diameter. They're tiny. And you can imagine that as you cut out these buttons, the coronary arteries are not sort of free vessels. They're embedded in the heart as well. You need to carefully dissect them and bring them over without kinking into the coronary arteries and make sure that there's no kinking that lasts for the entire rest of the life of this particular child. And here you see it after repair itself. So I think I have another minute or two for the talk. Let me show you a brief part of a video intraoperatively of transposition. So here's the aorta. The surgeon's holding the aorta. You can see the coronary arteries coming off this. There's the left coronary artery. There's the pulmonary artery that's being grabbed from behind and the left atrial appendage. But again, notice the aorta that's now being pulled over to the left. It is sitting way anteriorly. Off of it is coming the right coronary artery as well and the pulmonary artery behind it. And so what we're going to do is utilize hypothermic circulatory arrest and stop the heart to give us under an hour, hopefully, to get this operation done. Here you see the surgeon cutting into the aorta, which again is that very first vessel sitting right up front, coming off the right ventricle. And what I want to get to in the video, I think it's coming up in about 30 seconds, is a look at the coronary arteries. There's the pulmonary artery that's being transected. So the two vessels are transected, all done in as best as possible, a bloodless field. Look at the size of the fingers of the surgeons here and the size of these vessels. This gives you a sense of scale here as to what's going on and what's required to do this. And now what you'll see in a moment here is the bringing of one vessel in front of the other. This is known as a Lecomte maneuver. It actually has a name to it. You know, surgeons love to name operations, but this particular surgeon lent his name to simply a maneuver within the operation itself. But interestingly, it's referred to as the Lecomte maneuver. And again, the pulmonary artery now being brought up anteriorly, and the aorta will be positioned posteriorly. Here is the right coronary artery os. That's the ostium opening to the right coronary artery. Here's the button that's being cut out, which will then need to be relocated onto the aorta. So this is the main point of this little video here. Look at that tiny opening. And when you reconnect this button of tissue, you've got to make 100% certain you're not kinking the orifice. Look at the size of the instruments that are being used in the size of this orifice. And the proximal part has to be freed up enough so that you can relocate it and position it properly. So the coronary arteries are key to this particular operation. Where are we with this today? This is standard fare in congenital heart centers around the world. with excellent, excellent results. This is not any magic that's done in any one particular center anymore, as it was perhaps in the 1980s, but something that's done routinely at every major congenital heart center around the world. Outcomes are in the high 90% range, both short-term and long-term. From a survival perspective, I have to tell you, it was just maybe about 3 or 4 weeks ago, saw my most recent mom, who herself had transposition, an arterial switch, and is pregnant and carrying a fetus to term. And, we were just doing a routine screen of that particular pregnancy. But there are now an abundance of young women in their 20s and 30s who had this procedure done within the last 30 years, who themselves are becoming pregnant. And as I said earlier, very little genetic chromosomal transmission for this particular lesion. So we're doing the screening, and we're doing our due diligence, but we're not identifying any major heart disease in these fetuses. But it's a testimony to the magnitude of impact that this entire approach has had for this condition. What are we looking for long-term in survivors of TGA? We continue to worry about coronary insufficiency. As you grow from that little newborn with that 1 millimeter coronary to an adult, and you have the onset of atherosclerotic changes. How is that going to impact? We don't yet know, because we don't really have 50, 60, 70-year-olds yet who are succumbing to atherosclerotic disease to really see what the impact might be of coronary relocation. Some studies have shown that, interestingly, the coronaries do scar over and they can become kinked, but patients often don't know it because it's an early event in their lives, and that collateral flow can develop around areas of narrowing of coronary arteries, such that some kids don't even know they may have some of these obstructions, and so therefore surveillance testing is generally recommended. And then, interestingly, aortic root dilation is something that we're seeing as well, where at the site of the anastomosis, the site of the connections, there can be areas of aneurysmal dilation that can occur, and as a consequence as well, some valve leakage, aortic valve leakage, and such that we're dealing with. None of these are major things, but are items that we continue to survey for and look for as this population grows into their now later adulthood. And I could quote dozens, if not scores, of papers that are showing, again, excellent outcomes around the world for this particular condition. Again, highlighting the dramatic impact of a prenatal diagnosis, proper neonatal care, and a successful arterial switch. So TGA is a form of congenital heart disease in which dramatic improvement in outcome has taken place over the past 30-plus years. It's expected that most infants born today with TGA will survive into adulthood and lead a normal life. But prenatal diagnosis is critical to those outcomes. The things that we're looking for include coronary artery insufficiency and aortic root dilation as these patients mature into their later adult years. Thanks very much.